Good afternoon, everyone. Welcome to the Racial Justice Summit session on health. I'd like to let folks know that there is simultaneous French translation that's accessible by clicking on the globe interpretation button on the bottom of your screen. Pour ceux d'entre vous qui sont francophones, je tiens à vous faire savoir que nous avons une traduction simultanée en français. Pour accéder, veuillez cliquer sur le bouton du globe qui dit Interprétation en bas de votre écran Zoom. My name is Angela Lee. I'm the Partnerships and Research Director at the Canadian Race Relations Foundation, and I'm located on the treaty lands and territory of the Mississaugas of the Credit and traditional territory of the Anishinaabe, the Wendat, and the Haudenosaunee. This territory is within the lands protected by the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee and Anishinaabe and allied nations to peaceably share and care for the resources around the Great Lakes. Today, the meeting place of Toronto is home to many First Nations, Inuit, and Métis people from across Turtle Island, and I'm grateful to work, live, and play on this land. Before we begin, we'll show a short video to acknowledge the sponsors of this summit. Okay, thank you. I'm very much looking forward to this discussion this afternoon, and I hope you'll benefit from our panel of insightful and knowledgeable speakers. This session will focus on the theme of racial justice and health and brings together diverse experts in the field to discuss their current work and ways to address health and the impact on racialized communities. The discussion will be followed by breakout sessions where attendees will be split into breakout rooms to have a deeper discussion with one another, as well as panelists as an expert in each of the discussion. Let me introduce you to the panel right now. We have Dr. Fatimah Jackson-Best. She is a public health researcher with a specialization in mental health and whose work focuses on communities in Canada and the Caribbean. Dr. Jackson-Best is currently the project manager of Pathways to Care, where she is designing an intervention to improve access to mental health and addiction services for Black children, youth, and their families in Ontario. And we also have Jackie Silvera, a senior manager of diversity and mediation services at University Health Network. She has worked in public and private sectors in North America for over 25 years, developing and delivering inclusion, diversity, equity, and accessibility strategies. And we also have Baldev Mutta, who has been in the field of social work for the past 45+ years. He is the founder and chief executive officer of the Punjabi Health Community Health Services. PCHS is a health service provider in the central region of Ontario Health. So we have a great panel here today, this afternoon, very knowledgeable, and let's just get right into it and begin by exploring what the current and ongoing issues are around how this COVID-19 pandemic has impacted racialized communities or exacerbated already existing barriers. You'll each have 3 to 5 minutes to talk about how this pandemic has affected racialized communities. So I'm going to ask Jackie to start first. Oh, I think you're muted.
Okay, is that better?
Yes, thank you.
Yeah.
Perfect. Of course it is. Thank you. As we begin, I think it's important to acknowledge that it's not surprising, but troubling, the impact that COVID has had. The other thing that I would like us to note is that the race-based data is inconsistently collected and not readily available across Canada. Early on, it was clearly evident that racialized communities were being and are being disproportionately impacted by COVID-19. Toronto, Ottawa showed that the cases were 1.5 times to 5 times higher among racialized populations than non-racialized. Also, First Nations peoples and communities living on reserve were 69% at higher rates of infection. I think it's so important that we treat race as a local issue specific to events that are occurring, but we have to put meaning to the issue of race and context. The global impact of COVID is equally devastating in many countries across the globe, and it leaves us to really consider what is taking place. Racism, the disproportionate impact among communities, has a strong grip on existing health inequities that already existed and is influenced by the things that we all know to be true: socioeconomic, political conditions affecting income, education, employment, housing, which we refer to as the social determinants of health. Also, it's affecting racialized communities and people with intersecting identities, so the LGBTQ2S+ communities, homelessness, poverty, individuals that are incarcerated, and newcomers, to name a few. As we look at this, we also have to consider, which is tragic when we focus on it, the wage disparity that concerns, the harsh practices that financial institutions are engaging in, the inherent bias with those institutions and lending practices, the current situation with real estate and rental rates that have skyrocketed, not to mention the cost of food that has increased. So when you put this in context for individuals that were already burdened in a system, and then you add the layer of COVID on top, it's devastating to think. If that isn't enough, I would say the situation has been exacerbated for members of the communities with increased incidence of joblessness, underemployment, precarious employment that is cropping up faster than we are actually paying attention to, and temporary work, which is forcing racialized worker into essential jobs that are publicly facing with very little protections. StatsCan reports that racialized people represent approximately 1/3 of long-term care workers. That includes nurse aides, orderlies, patient service associates, and of course the proportions of the representation in those types of job, Black, Filipino, and South Asian workers. The frontline occupations, again, if it wasn't now, I just keep delivering more bad news, they're usually and typically unionized positions, which means the jobs themselves are governed by collective agreements. So the capacity to be nimble and adjust to quickly changing situations, it's not possible. So individuals are stuck, especially in emergency situations. There are other types of work that are exacerbated by COVID, agriculture, in corrections for the individuals that are housed in correctional centers and the workers themselves. And then we know that there are higher reports of COVID due to overcrowding. I'm going to end on the impact of harm for racialized people and communities during COVID has been further exacerbated by the explicit use of stereotypes, tropes, and epithets based on race that have been propagated even by world leaders. This includes increased acts of racial aggression and violence, which many of us suspect is underreported, and the aversion that we know to be true, and again, based on real experiences, is worsened by this situation. While statistics report increasing rates of mental health crisis, again, we believe that this is underreported, and the impact, the exacerbated impact that this is having on our communities requires much attention, correction, and addressing, which we are going to talk about later. Our histories combined with the current realities of discrimination, racism, including the limited access to health and social services, has again just further deepened the intergenerational trauma that our communities face. It has put racialized people and communities at increased risk to experience inequitable treatment that the system promises to have corrected.
Thank you, Jackie. Such a great breakdown of a lot of bad news for sure. Fatimah, I'll turn the mic over to you. Same question. How do you think the pandemic has impacted racialized communities or exacerbated already existing barriers?
Well, thank you so much for the question. And thank you, Jackie, for laying such a thorough groundwork of what has been happening when it comes to racialized communities. To be honest, a lot of the insights that I can provide cover some of the same discussions that Jackie just went over. I will say that as we know, or as we should know, from data that has been collected in cities like Toronto, which is where I live, we saw that communities of color, specifically though, Black communities and Southeast Asian communities, had higher cases of COVID-19 and also higher rates of death. And a lot of that had to do with the fact that many Black communities are living in contexts where, there are intergenerational homes where there are many people in one dwelling. Also that there were many African descendant people and Southeast Asian people who are in front-facing jobs, whether that's in factories, hospitals, food services, etc., which put them at a heightened risk of contracting COVID-19, and then underlying chronic illnesses that have been plaguing our communities for, pre-pandemic, worsened outcomes in terms of death. So it really was a chain link of factors, of social determinants that created this context that we had, where we saw Black communities and Southeast Asian communities bearing the brunt of these of the pandemic, of the cases and of deaths during the pandemic. And of course, it's not even an accurate or a holistic look at it, because we don't know what's happening to Black communities who live in cities like Windsor and London and other places where race-based data was not collected. We also know that our province refused, our provincial government refused to collect race-based data, which could have told us a lot more about who's contracting COVID-19 and could have led to quicker solutions for communities. One thing that we've also seen with regard to the pandemic is that we've also seen, especially in the beginning of the vaccine rollout, communities who were hardest hit in the northern corridor of Toronto being the least, having the least access to vaccine clinics and the vaccines themselves, which just exacerbated situations. So, again, a real failure that we saw in terms of getting people life-saving interventions for COVID-19 as well. I would say that some of the, the existing barriers that have been exacerbated are ones of geography. We may live in Toronto, but our access to life-saving interventions, vaccine clinics, healthcare, et cetera. It's not uniform across our city. And especially if you're living in neighborhoods where, it takes you several, 30-minute buses and also a subway to get to your healthcare provider. Even before the pandemic, this was obviously exacerbated during the pandemic. I would say also, because a lot of my work deals with mental health, what I've been seeing and hearing through my work with the Black Health Alliance and the project that I've been designing Pathways to Care is really worsened mental health contexts and experiences for people of African descent, because most of my work deals with Black communities and mental health or mental health of Black communities. And so what we've definitely been hearing is, more fragmented services, less front-facing services, particularly during lockdowns, but then also heightened, heightened mental health challenges like stress and anxiety and depression due to our lockdowns that we experienced, and due to, already existing fragmented services. The mental health outcomes for Black communities, I would wager to say is incredibly worsened since the pandemic. There's some other things that I want to say that are more specific to mental health services and the overlay of where Black communities are more densely populated, and also where we were seeing in places like Toronto, COVID-19 rates being quite high. But I'll leave that, I think, for the next part of our discussion.
Okay, thank you. Thank you very much. And talking about how service delivery and all the different barriers that are impacting racialized communities there. And then my own interest in data collection, definitely. So next, I'll turn the question over to Baldev. Can you talk a bit about how the pandemic's affected racialized communities and exacerbated barriers?
Yeah, thank you for the question, and thank you to Jackie and Fatimah for laying the foundations for us to build on their wonderful initial remarks. I will just add 2 points to the discussion. One is the chronic underfunding in certain parts of our healthcare system. There is geographic underfunding in certain communities. And then if you look at a little bit more narrowly, then you will see that the organizations serving diverse communities get even lesser funding than the mainstream. So there is some systemic issues that were already highlighted prior to pandemic, and as a result during pandemic it became even more intense, that we were already underfunded and we had virtually nothing to respond to. So that is one kind of systemic issue that we need to kind of elaborate and do. And the second thing is, how is the healthcare system in Ontario? When we look at it in Ontario, the for-profit of long-term care. Now, if we looked at the tragedies that happened in the for-profit of the long-term care, we see that the chronic motivation to make profits resulted in less staff being appointed towards taking care of the seniors. So we had serious tragedies happening within these long-term care facilities. And still, I think that the gravity or the magnitude of the tragedy is not being understood by the current system, that in order for us to make a difference, we need to really examine the core issues that are at hand. Can for-profit deliver healthcare in a manner that is acceptable to the community, or is that just an avenue to kind of make more money at the end of the day? So I think those are the systemic issues that we need to raise it at a higher level, that we can really address. Why is it impacting the marginalized communities? What is the devastating effect? And even if we are talking about recovery now, is it going to be impacting that we as marginalized communities will be least benefiting from the recovery of the investments that the provincial and the federal government will make? I think that is something that we need to discuss a little bit more at the systems level.
Thank you, Baldev. That's I fully agree. There's definitely a lot of questions around funding, and especially around long-term care and the for-profit motive there, and whether or not that is it coincides with actual healthcare delivery. I want to move more towards how our panelists are seeing things in their own work. And Fatimah, I think this will build a bit off of what your opening remarks. But how do you think COVID has further exposed racial inequities faced by Black communities?
Yes, I mean, I think COVID has, like every infectious disease outbreak, every mental health crisis, etc. I think that it really has laid bare the fact that we live in an incredibly inequitable world, inequitable city, inequitable province, inequitable country. What I taught this to my students last year at York University. We were talking about the social and political, the class was about the social and political context of illness and of infectious disease specifically. And one thing that I impressed upon them was that, every illness, every outbreak, every infectious disease has social and political underpinnings, right? And one way that we can see it very clearly is how it disproportionately impacts certain communities, whether they're racial, ethnic, etc. And so, one thing I really showed them, or there was a map that had come out I think from the city of Toronto, I'm pretty sure from the city of Toronto, that showed where COVID-19 outbreaks and spread was happening more quickly. And, it really focused on, well, it really showed us that a lot of those outbreaks, at least in the city, were were happening in the northern corridor. So, north of, Shepherd, west and east of, I guess, west of Dufferin, etc. So that, as they call it, the northern corridor. And if you look at the Census Canada dense Black population density, we know that a lot of Black communities live there. And then when I saw that map and I saw that the northern corridor was, and also when you look, further south in the downtown core, you saw less COVID outbreaks. And we also know when you look at Census Canada, you can see that there are fewer Black communities who live in this area. And also that, the incomes of people goes up when you go further south in Toronto, to the downtown core, etc. And then I started thinking about a map that we had developed for Pathways to Care. And you can see this map on our website, www.pathwaystocare.ca. And we developed this social network analysis map that showed where mental health services are across the city. And we also have it across 5 other cities in Ontario. But for Toronto, I'll specifically speak upon it. And so what we did was that we overlaid, all of the services that we had surveyed and saw, are they a Black-led organization, a mainstream organization, et cetera. We found out all of that, we placed them on a map, and we overlaid that map with the Census Canada Black population density. And what we saw was that although a lot of Black communities are living in that northern corridor, most of the mental health services are not in those neighborhoods. They're mostly concentrated downtown. And so it really, to me, it was very striking because it was a direct mirror to what we were seeing with COVID-19, right? More Black populations, less access to testing, less access to vaccines, less access to mental health care services, and that these were all, a lot of these were concentrated in the downtown core where people had more resources, right? So this is an inequity, right? This is a social determinant of health. This is socioeconomic status. This is racism. Race is not a determinant of health. Racism is. And all of these inequities are really fueled by systemic and institutionalized racism. And so COVID just monopolized that, right? And it was an opportunity for more Black people, people of African descent, to get sick and pass away and pass on this virus to other people in their families. So this is a long-standing issue, and I think that when we're talking about, how do we develop a COVID response, we have to address the underlying factors that deal with socioeconomic status, with racism, systemic and institutionalized, and all of these other factors that make it so that when an outbreak or when a virus or when an illness impacts or reaches Black communities, it impacts us in devastating ways.
Mm-hmm, definitely, and certainly we could really see that on a map and map out communities that are more racialized in geography. Absolutely. Jackie, I want to ask you, can you speak towards the prevalence of systemic racism within health institutions?
I got to get better at that.
Great.
So thank you. Fatimah, thank you so much for laying out the geopolitical frame. It's so important to the discussion around systemic racism. And, as we contemplate this, I think we would be remiss if we don't go back to the idea that racism started with history. It started with the history of institutionalized discrimination against racialized and indigenous communities all across the world. It's perpetuated by this thing that we frequently refer to as systemic racism, which is, the idea of a neutral policy or a practice that when applied to particular groups has a disparate impact and decimates that community. I often refer to it as 21st century colonialism or 21st century imperialism. And it's perpetuated by racial power dynamics that is born from imperialism, slavery, and colonialism, forced removal from traditional lands, appropriation of resources, forced assimilation, including the subjugation and elimination of markers of identity, including language and religion. And then, of course, the socioeconomic, political, educational, residential, and occupational segregation, which Fatimah just spoke to us about. As I was preparing and thinking about this discussion, I thought more about the prevalence of systemic racism and the roots of that. And it's all based on a false ideology, based on simple common stereotypes that is focused on biology. It's all mythology. So as I started looking, I am not a clinician, so Fatimah, you jump in here at any point. But the idea of high pain tolerance, physical strength, low intelligence, reproductive ability that goes back to the 1600s and is still living and thriving today. It's an organized way to make inferior and justify the bondage and the enslavement and the human trafficking of racialized and indigenous peoples. And this ongoing race-based myth about biology continues within research and medical conventions today. So as we think about various standards that exist in healthcare, BMI scales, bone density, belief that patients have longer nerve endings and thicker skin, as we start thinking about these common mythologies that exist and perpetuate this thing that sustains systemic racism within healthcare and treatment, I started asking the question, so what do these assumptions really mean? Well, this is what it means. BMI risk for diabetes. Asian patients are considered at risk for diabetes where they have BMIs that are more than 23 versus 25. The outcome of that is Asian patients are screened. And when I say Asian, I'm just using the language that is in the literature, is screened for diabetes despite the absence of any risk factors. So what that does is it's stigmatizing a whole class of people, a whole group of people in unnecessary ways. I go one step further. There's something called the EGFR, and that has everything to do with this presumption that Black people have a higher musculature, higher muscle mass is the easiest way to say it, and creatinine generation. What that means is Black people may experience, and when I say may, it's a very small may, experience delayed dialysis and transplant referral. I'll give you one more, GNC8, hypertension guidelines. And what that means for the Black communities is that they are likely less prone to receive active hypertension control. So as we go through all of this, and we have the conversation about systemic discrimination within healthcare, we have to ensure that we are paying attention to the mythology that is being perpetuated in the very research that is making us sicker. The idea of the thicker skin. So remember, I made the comment about thicker skin results and the myth that Black people, Black patients feel less pain. That results in the prescribing of less pain management and appropriate or accurate treatment and recommendations. They did a survey of mock medical cases, and that has been continual. There has been no change. So training hasn't changed to break that convention. But it also includes, as I said before, the stigmatizing, and I would add the profiling based on this perception of drug use. I can share with you, I had surgery earlier this year, and I was one of those individuals that didn't receive pain meds immediately and had to pretty well fight for it. There's lots to say, but to sum it up, I would say, in other words, racist assumptions about biology of racialized peoples is embedded in the very core of the health system that we are relying on. It is serving to make us sicker. It is perpetuating the disparity in treatment and the inequality that results in care. And it continues to impact healthcare and outcomes that is leaving us exactly where we are. So I know we're going to speak to this. This is much more than COVID. This is embedded in the very fiber of our healthcare system.
Mm-hmm. Absolutely. Jackie, thank you for that overview of the hundreds of years of racism and how it's impacted our healthcare and just the study of our bodies and like our physical bodies, and certainly how those stereotypes have impacted us, through to now. And I feel like that was a real masterclass. Thank you. We've talked a bit about the physical body, but I want to talk a bit about about mental health and health equity. Baldev, in your work with the South Asian community and addressing mental health and family dynamics, how has the pandemic affected or reaffirmed any findings?
Just one pre-comment to support Jackie's just position. I think one of the struggles that our communities are having, the Black community and the South Asian community and other communities as well, is that we don't get professionals that look like them, that think like them, that understand the underlying meanings of the illness. And I think that is a big institutionalized artificial created barriers by saying, oh, we didn't find the right qualified person for this job. So therefore, we don't have social workers, we don't have psychologists or other professionals from the community. And I think that entire system within the institutional, that framework needs to be changed. They need to really acknowledge this, that you cannot do clinical intervention by bringing in interpreters. You can do an intake. You can do an intake where you ask somebody a name and the person translates the name. You say, why are you here? They say, because I'm experiencing this particular symptoms. So you translate the symptoms. But to actually do clinical counseling with interpretation, I don't think so that's going to work. So I think that needs to be really looked at. And I just wanted to strengthen what Jackie had so eloquently elaborated in terms of this. Now, in looking at in terms of within the South Asian community, so from the ground level, what are some of the experiences now that are happening at Punjabi Community Health Services in PO? We have looked at that there is an increase in terms of accessing mental health services. So we have a wait list now. Now, remember when we were all hearing, oh, that there is a stigma of accessing services? Well, we don't see any stigma now. So is there a connection between people saying that, oh yes, certain communities have stigma around mental health? And I still hear this a lot, but can we turn this around by saying that if you have lack of access, well, then perhaps we can say, oh, people are not accessing the services because there is stigma. But I thought that, that there is, and we have tested the hypotheses about stigma. We took our mental health case managers inside a Sikh temple to explore, if we set up a display, would people even reach? So if there was stigma, our hypothesis was nobody will come to us. Nobody will talk to us because there is stigma. People don't want to be associated. But to our surprise, we had a lined up to talk to people, open, everybody saw, everybody talking. So I was baffled that I was convinced initially through this whole dialogue that yes, our community experiences stigma. So now I am beginning to say, no, maybe there is some truth that there might be stigma, but more truth is, as Fatimah had outlined and as Jackie had outlined, that where are the access? So if somebody is going to travel 50 kilometers to see a therapist, maybe we need to consider, maybe it's not lack of stigma, or maybe it's not because of stigma that they are not going, it's because of no access to services. So I think that what we are now beginning to see is that a lot more people are accessing our services. Last year, we had a higher number of South Asian men die of opioid drug use. We had high increased number of violence against women in the community, which every other community also experienced. So underlying this whole system is not that somehow there is much more incident. I think that people are now beginning to understand that if we can access, and that's my kind of understanding, that if we are able to seek vaccination, if we are able to go and address some of the challenges we are facing within pandemic, then why can't we get some help around? My teenager doesn't want to listen. He says, no, it's okay, Dad, let me go out. And the parents are saying, no, you don't go out. Don't put yourself at risk, because if you come in with COVID, we will be also sick, or your grandparents will be sick. I think that those complexities have now increased. There is increased demand, but then again the cycle hits. The systemic racism comes in. Well, there is no additional funding for our organizations. And I think that's where we get into double bind. So do we do all this good work, raise awareness in our community that, yes, we are here to help you. And then they come to help, and now we're going to put them on a waiting list. And I think that is what we also need to struggle, is that when we do outreach in our community, we talk about these systems, and then all of a sudden resources aren't there, people become dejected. And they say, well, you are the ones who were telling me, come seek help for my depression. Now I'm here. Now you're saying I have to wait 4 months. What is this? I think those are some of the challenges that we need to see. What does equitable funding allocation mean in the province of Ontario within the health sector? Why are bigger organizations getting the bigger share of the pie all the time? So when they say we are using equity lens, what equity lens are they actually using? What equity lens is there? So if somebody has a bigger funding, and let's say the base funding increases 2%, so they will get the bigger part of the shares. So we are then again left behind because of there. So they are saying they are using equity lens, but I personally have some serious issues with the way they are interpreting equity and the allocations of funding and our ability as organizations and professionals to be able to provide the services that our communities need.
Yes, I completely agree. I think that there is such all of the panelists have definitely illustrated just the need and the inequitable access to health services throughout, and especially among for racialized communities. Before I move us along to our next set of questions, I just want to let participants know that at about around 3 o'clock, we're going to be going into breakout sessions after the panel. The choices are mental health and race, COVID impact on racialized communities, health institutions, and organizational change. If you're joining from a browser, you will unfortunately not have the option to choose. So you'll have to change your Zoom name and either put race, impact, or change in brackets. And our technical crew are going to move you there after this panel discussion. So then just to reiterate, we want to break you out into breakouts, and if you change your name to either race, impact, or change to reflect which breakout room you want to go into, then our technical crew can move you into the those breakout rooms, and they'll do that as we're talking, definitely. We've talked a lot about, just generally the issues that racialized communities are facing around health and equity and access and mental health and there are so many factors really. And you've talked about your own work and what you're seeing in your communities. But I want to start to talk a bit about solutions or what people can do. Baldev, what have been some of the areas where support is needed in the context of mental health, and some of the ways that this can be carried out?
I think one of the ways that what we have done is we deliberately took a stand that we have an organization and it serves the Black community. It's called Roots Community Services. So we lobbied really hard during a pandemic that Roots Community Services should be given their own funding. It should not be channeled through another service provider, because they are a health service provider. They have been providing health services. They should be getting so one thing I would say that in order for us to develop a cohesion, we need to have a united front of all the communities who are struggling, and the Black community was struggling, the South Asian community was struggling, and many other communities were also struggling with the direct impact of COVID. So we need to also partner, and we need to stand up for each other. And that was one concrete example where Roots Community Services got their funding. Now we are lobbying hard that if you want the Black community in Peel region to be served appropriately with cultural safety and cultural appropriateness, you need to give funding to Roots Community Services and not have a mainstream organization take away the funding and then hire some staff to provide services. So I think that whole model where mainstream organizations are saying, okay, give us the funding, we will hire a staff, we will deliver services, versus an organization that has the capacity to do the same job better. Why aren't we giving them? I think that has been highlighted and that has been strengthened, and we need to maybe perhaps work more on those ideas. That is one concrete example. The second thing is, what can we learn from each other? So one of the things what we learned from this pandemic is how can we support each other? So when there was a vaccine clinic organized within the Black community, we all supported whatever staff we can send to support them. And when there was a vaccine clinic that we had organized within the South Asian community, all other agencies kind of supported us with sending their resources. And I think that support is needed to demonstrate that now we are actually united and that we would fight for our fair share, and that we would not accept your answers that yes, we are using HERE tool or we are using equity lens. We don't want you to use equity lens. We want us to be given the amount that we deserve that to be given. And I think that's what has highlighted, and that where we have seen actual results that we need to partner more amongst ourselves. That has been the lesson learned for me during this pandemic.
Thank you. That's a clarion call for sure in terms of banding together. Similar question, Fatimah. What are, from your perspective, what have been some of those areas where support is needed in terms of mental health and some of those ways that it could be carried out?
Yeah, so I think that, there's so many areas where I think support are needed and that have been really amplified during the COVID-19 pandemic. And I think that, of course, we absolutely need more mental health care providers who can support Black communities. And that includes, of course, making sure that these providers come from these communities, right? There's a lot of potential. There's opportunities for people who are not from Black communities to support Black communities when it comes to mental health, but understanding the nuances and the specific needs and the context, et cetera. Sometimes it requires having somebody that is from the community and is familiar with it. What we know about the availability of Black therapists and service providers is that most of them work, or many of them work in for pay area, right? So unless you have insurance or unless you are able to receive some sort of funding to pay for a Black therapist, your options become quite limited. And I think that for me, like when I've been thinking about how can we change this, and how can we, the next time something large in terms of, something like a pandemic happens to us, how can we prepare so that we are ensuring that mental health is going to be adequate for Black communities? And one thing that I really came to grips with was that we have to completely transform the way that our healthcare system is structured. We pride ourselves on being a universal healthcare system, but mental health care is not a part of that universal system. Same thing with dental care, but that's a separate issue. And so I think that, you know, on a systems level, where we can really see equity, you know, across the board be enacted, it would be to include mental health as a part of our OHIP coverage, right? And, you know, I think that, you know, when people hear that, you know, there's immediate response of like, oh, this is so far-fetched, etc. But, you know, we have to think beyond, you know, Band-Aid solutions, and, you know, how do we deal with this for now? We have to look at the very systems that we are living within and that have been created, and the ways that inequity, you know, manifest in those. And so, yeah, I think that's, you know, we need more Black therapists, we need more Black practitioners, but we also need to have a system where Black communities are actually able to access those practitioners and those service providers without having to go out of pocket, and also where practitioners and providers are adequately, you know, paid and reimbursed for their services, right? So we need a complete overhaul, I think, in that respect.
Absolutely. I think definitely that's one of the byproducts of the pandemic, that where we have this ability to dream bigger and ask for more, and to advocate for more, and really drill down in terms of systemic change, and including mental health care into OHIP seems like something that is really, really very much needed throughout. Jackie, what are this is an easy question for you. What are some of the main barriers to seeing the solutions that we need implemented, and how can these barriers be overcome?
First, I wanted to comment on Baldev and Fatimah. Collective activism and advocacy is so important. And as we think about systemic racism, you know, with its roots in imperialism and colonialism, it actually is designed to pit us against each other. So, you know, I'm so pleased to hear that called out. I was going to spend some time, you know, talking about the examples and how privilege itself is manifested within, you know, this whole regime. I'm going to skip that and share this comment. And a researcher, Yancey, said that the inequities are not a result of the COVID pandemic itself, but rather a system and symptom of a much more pervasive issue of racism embedded within societal policies, practices, and institutions. I also believe that reform is required, and reform that shifts racializing the very work. The work is racialized, and it is not designed to make the transformative change that we need. Krieger, and, you know, I'm sorry, I'm quoting individuals, but identified these 6 pathways within which racism harms. And if we are going to do this well within the context of reform, we have to acknowledge, proportionate to racism, how individuals are being harmed. So that is recognizing the economic and social deprivation, recognizing the toxic substances and hazardous conditions. So, you know, as I'm at point 2, it's taking into consideration environmental racism that is also extremely embedded within this conversation, as Baldev and Fatimah pointed out, the geopolitical redlining that is occurring. Acknowledging the socially inflicted trauma, mental, physical, sexual, that is perpetually experienced, witnessed, from whether it's verbal threats to violence, targeting the marketing of commodities that harm individual within healthcare itself, and whether that's alcohol, tobacco, and it is pushed on our communities. Identifying what constitutes inadequate or degrading medical care, and identifying the degradation of ecosystems that are linked to the systemic alienation of peoples, populations, BIPOC peoples. Now, as I jump onto what do we do, in alignment with reform, there needs to be oversight within the healthcare system, and that oversight needs to be arm's length. There needs to be the development of real anti-racist strategies and programming, and I take Baldev's point, not through an equity lens, because nobody knows what an equity lens really is. But this to be informed and led by the communities that are harmed and the communities to be served. The notion of health standards that regulate reporting and public reporting that includes the collection and monitoring of race-based data. The implementation of standards of foundational programs that speak to funding, governance, education, inclusive leadership that addresses low representation rates of BIPOC, HSPs, and is based on an accountability model, which my esteemed panelists have already said. And, you know, the last thing I will say is, since racism has been declared a public health crisis, it should be treated as such. The mandates to propagate and address these breaches as they so frequently occur needs to be embedded in the accountability framework. So, you know, if I were to sum it up, I would say that all levels of government, from municipal to federal, you know, really need to work together to ensure that as we discuss funding formulas and the allocation of resources, it needs to be done in a way where there is community benefit.
Mm-hmm. Mm-hmm. As I'm sitting here thinking about Jackie, Baldev, Fatimah, all that you've said so far in this afternoon, you're all brilliant. It's been an honor to moderate this session. I somehow find myself doing this, but I definitely thank you in terms of your insights and the knowledge that you're sharing with us.